for psychological therapies for adults with binge eating disorder. This is the same as the last two presentations, so I'll not revisit here. Altogether, we found 8 psychological therapies that have been tested in people with binge eating disorder. 2 of these therapies had at least 2 high-quality RCTs. CBT has by far and away the most empirical research evidence related to it, and results consistently show positive outcomes for CBT, non-active controls or waiting lists in terms of reducing binge eating frequency, achieving abstinence, and in terms of reduction of eating disorder psychopathology. The medium-term efficacy of at least a year has been confirmed, but we really would benefit from further studies looking at longer-term follow-up. As we know, there is different modes of delivery of CBT, and all of these tend to outperform non-active controls. But when the comparative efficacy is looked at between each of them, the results are inconclusive, and further research would really help with service design and delivery for people with BED in terms of what mode of delivery might be most helpful when. Furthermore, the studies that have looked at therapist-led interventions have been mainly group rather than individual. Overall, CBT hasn't been found to achieve reductions in BMI, which isn't a target of the treatment anyway, and results with regards to depression outcomes are mixed. There is also little evidence to suggest that CBT outperforms other therapies, but it is consistently comparable and there is more research evidence. In terms of IPT, one meta-analysis looked at 2 RCTs, which were both head-to-head with CBT. What they found was, or they concluded, there was modest support for IPT, and IPT and CBT were comparable in that they were as effective in addressing remission, reducing binge eating frequency, and reduction in BMI at the end of treatment and at 12 months follow-up. These studies all had at least one high-quality RCT, and of these, DBT has the most research behind it. DBT seems to outperform waiting list controls on a range of primary BED measures. However, when there's active comparators, the results are less convincing, usually finding no differences. There isn't a meta-analysis available for DBT, and the only head-to-head study with CBT is within a mixed sample. There seems to be some mixed findings for GPIT with a systematic review suggesting it was comparable with CBT, but a more recent RCT questioning whether it added any benefit to unguided self-help for CBT. BST, ST and ICAT all have one head-to-head comparison with CBT. BST actually found some outcomes that were superior to CBT, and ST and ICAT were comparable to CBT. CFT really has small pilot RCTs, and one is in a mixed sample, so we can take limited information from that. I think it's important also to look at psychological therapies versus behavioural weight loss, given that a significant proportion, certainly not all though, of people with BED are overweight or obese. Psychological therapies don't target weight loss, and so there may not be a reduction of BMI. They are generally likely to be more beneficial in addressing the eating disorder though. Interventions with a primary focus on BMI reduction are ineffective in their primary aim, however, because people tend to regain the weight they've lost over follow-up. So based on all the research evidence, this is the recommendations that we've concluded with CBT or IPT as first-line treatments, and also some recommendations or considerations for those that are overweight or obese that we've discussed. Finally, this is the good practice points, which are the same for anorexia and bulimia and equally as important with people with BED. Thank you.